Hi everyone, our subject today is fever in the intensive care unit. Introduction. New onset fever, defined as fever occurring after 48 hours of admission to the intensive care units in a patient who was previously afebrile, is generally considered as a sign of a hospital-acquired healthcare associated or nosocomial infection. However, an infection may occur without fever, and not all fever is due to infection. In certain circumstances, a new onset fever may also be a continuum or a complication of a community-acquired infection. Distinguishing infectious from non-infectious cause of fever, it must be remembered that fever can often be the result of non-infectious causes. Non-infectious causes of fever in the hospitalized patient include postoperative atelectasis, drug fever, thrombophlebitis, transfusion, deep venous thrombosis, central fever, etc. Similarly, leukocytosis may not always be due to an infection. Non-infectious causes include stress, bleeding, atelectasis, and steroid. Distinguishing infection from colonization in the nosocomial setting. In several ICUs, surveillance cultures are sent for non-sterile sites like endotracheal tubes, central line ports, urinary catheter, and EVD drains. These will always grow microbes as these sites are inevitably colonized. It is important that these colonizations are not treated with the antibiotics, as treating colonization will not prevent infection and only contributes to selection of resistant organisms. Unless an infection is suspected, no surveillance culture should be sent. More difficult is to differentiate infection from colonization in the setting when fever is associated with the positive cultures from non-sterile sites. Here, careful interpretation is needed to ascertain whether the positive culture is colonization or true infection. Determining the site of infection. Common sites if infection in the ICU are bloodstream infections, especially in patients who have central lines, sinusitis, tracheobronchitis, pneumonia, in patients on intensive invasive ventilation, urinary tract infection in those who have indwelling catheters, surgical site infection in post-surgical patients, and sometimes enteric infection. Clostridium difficile is less common in children as compared to adults. Central nervous system infection and intra-abdominal sepsis should also consider in children with the predisposing procedures interventions at these sites. Occult site of infection includes sinusitis, osteomyelitis, and septic arthritis, eliciting symptoms referable to a particular system is often difficult in very sick children, but should be done whenever possible. A head-to-toe assessment should be done with the careful inspection of the central line, exit site of central venous respiratory system, natural of tracheal secretion, abdomen, bones, joints, examination of neck stiffness and surgical sites and skin. It is important to disrobe and examine the entire skin, as these might show area of cellulitis, scars, pustule, which often indicate bacteremia or fungemia. How to approach to fever in ICU. Exclude non-infectious causes, clinical examination, complete blood count, C-reactive protein, procalcitonin, blood cultures. If there is no focus identified clinically, send for urine analysis and culture. If there is possible focus identified clinically, culture from relevant site and imaging study. If the patient seriously ill-looking or not. If it is not seriously ill-looking, wait for the result of investigation. If it is seriously ill-looking, consider removal and change the central line. Empiric therapy with the suitable gram-negative cover, beta-lactam, beta-lactamase inhibitor, carbamazepines, and anti-MRSA and antifungal. Investigation approach. The initial investigation include complete blood count and peripheral smear evaluation with the acute phase reactant such as C-reactive protein and procalcitonin. Signs of sepsis include neutrophilia, neutropenia, thrombocytopenia, shift to left, bandemia, and toxic granules in the neutrophils. While C-reactive protein has limited sensitivity specificity for diagnosing sepsis, a serum procalcitonin level of more than 2 nanograms per milliliter is highly specific for serious bacterial infection in a previously stable patient. Procalcitonin can also be high due to previous surgery, trauma, birth, etc. At least 2 aerobic, 1 aerobic, and 1 anaerobic culture should be sent. If there is a central catheter, then 1 culture should be sent from the catheter lumen and the other from the peripheral venipuncture. Increasing the volume of blood culture by sending 2 sets of culture, 4 bottles, increase the sensitivity. Confirmation of the diagnosis of a catheter-related bloodstream infection involve isolation of the identical organism with the same antibiogram from simultaneous cultures, one obtained through peripheral venipuncture and the other either catheter lumen blood culture or culture of the catheter tips. A positive lumen culture alone has poor positive predictive value for the catheter-related bloodstream infection, as it may just indicate colonization, but high negative predictive value, more than 90%. In all children, and especially those with the suspected urinary tract infection, a routine urine analysis and culture should be sent. Result of this investigation should be interpreted carefully as some degree of pyuria and significant bacteriuria, colony count of more than 10 power 5 per milliliter may be seen in any catheterized patient with no urinary tract infection. For suspected hospital-acquired pneumonia, cultures of the respiratory secretion should be sent. Several methods like quantitative endotracheal aspiration, bronchoalveolar lavage, protected specimen brush have been recommended for diagnosis of pneumonia. General speaking, a quantitative culture of endotracheal secretion are easily done and of almost comparable yield as those of the bronchoscopic methods. Hence, in suspected ventilatory-associated pneumonia, combination of fever, leukocytosis, purulent secretion, new infiltrates, quantitative endotracheal culture should be sent and empirical antibiotic therapy initiated. Culture should also be sent from other suspected sites of infection such as surgical site, cerebrospinal fluid, abscess. Care should be taken to send deep samples, skin, swab, and culture from drain may just indicate colonization. Imaging also assists in diagnosing site of infections. Basic imaging include chest X-ray and ultrasonography of abdomen. Presence of a new infiltrate on chest imaging is also not specific enough for a pneumonia, as it may be due to atelectasis, progression of underlying lung disease, or due to thoracic surgery. In some patients, computerized scan of the thorax and abdomen may be needed to detect site of infection. Factor determining choice of antimicrobial therapy. Previous antibiotic usage. This helps in predicting the likely resistant profile of the microbe till culture results are available. Additionally, it helps in guessing what pathogens have not been appropriately covered till now. Severity of infection. For a patient who is critically sick or in septic shock, carbamazepine may be needed as there is high organism load and there is no leeway for making an error in choice of antibiotic, nor is there time to upgrade. On the other hand, if there is doubt about the presence of infection or there is mild infection, beta-lactamase combination may be used. Associated comorbidities. These are important consideration. For instance, if there is associated renal compromise, nephrotoxic drug such as aminoglycoside, vancomycin, and colchicine should be avoided or used with caution. Site of infection. In the presence of a CNS infection, a drug with a good CSF penetration must be used. Hence, beta-lactamase combination cannot be used as the beta-lactam inhibitor does not cross the blood-brain barrier. Local epidemiological data, knowledge of common microbial pathogen and their resistant profile in a particular intensive care unit helps in making empirical choice of antibiotic till culture are available. The most common etiological agents for nosocomial infection in India are gram-negative pathogens, including Klebsiella, E. coli, Pseudomonas, Acinetobacter, Enterobacter. These are followed by gram-positive, including Staph aureus, S. epidermidis, and Enterococci. There is an increase in infections due to fungi, mainly Candida albicans, but also non-albicans Candida such as Candida tropicalis, cruzi, globerata, and paracelsus. Most of the nosocomial pathogens are multi-drug resistant. Foremost is drug resistant in gram-negative pathogen, with the 80% of nosocomial E. coli and Klebsiella infection being resistant to the third-generation cephalosporin by virtue of the production of extended-spectrum beta-lactamase. The emergence of AMP-C-mediated resistance traditionally found in the Pseudomonas, Enterobacter, Serratia, Citrobacter, but now even in the other gram-negative bacilli has made third-generation cephalosporin and beta-lactamase inhibitor combination ineffective. The fallout of extended spectrum beta-lactamase and AMP-C-mediated resistance has been excessive use of carbapenems in the ICU setting. Consequently, a significant proportion of Pseudomonas and Acinetobacter isolates in the certain ICUs of the tertiary care hospital are now resistant to even carbapenems. This has led to colchicine overdose and sporadic reports of colchicine resistance. Staph aureus are generally methicillin resistant, vancomycin resistant. Staph aureus Enterococci are not a problem as yet. Also seen over time with the increasing use of fluconazole for therapy and prophylaxis is rising incidence of non-albicans Candida infection, some of which are fluconazole resistant. Clinical peers. A robust infection control program is crucial in preventing healthcare associated infection. Appropriate antimicrobial therapy is essential for improving outcome and reducing the burden of antimicrobial resistance. Knowledge of local microbial flora and susceptibility helps in designing empirical regime. A new onset fever in intensive care unit may not be infectious. A careful examination is needed to identify the source of fever. Relevant culture should always be sent prior to starting antimicrobial therapy. Result of investigation, including culture from non-sterile sites, should be carefully interpreted. The empirical antimicrobial therapy should be guided by local susceptibility pattern, severity of illness, and prior antibiotic use. It should be broad enough, especially in sick patients. Efforts should be made to escalate antimicrobials at the earliest. Infection control strategies are paramount. Thank you for your listening.